Okay, thank you for the committee, APSC, for inviting me to have a presentation about cardiac rehabilitations. My name is Badai Bhatara. I am a cardiologist. I have been graduated for a fellowship program in National Harapan Kita, Jakarta. Right now I'm a cardiologist and supervising a preventive cardiology divisions in Hasan Sadikin Hospital Bandung, 2 hours away from Jakarta, capital city of Indonesia. So cardiac rehabilitations, bridging the gap between evidence and practice. I will talk about essential role of CR in post-CAD, MI, and heart failure, the challenges, particularly in Asia, about its implementation, and also strategies to translate the proven benefits of CR into real-world practice. Cardiac rehabilitations, multidisciplinary intervention, whose core components are well recognized, including patient assessment, management, and control of cardiovascular risk factors, physical activity counseling, prescription of exercise training, dietary advice, psychosocial, and vocational support. Delivery of comprehensive program is essential to ensure favorable outcomes and expected cost effectiveness. Okay, the essential role of CR. So I will bring the consensus recommendations of Asia-Pacific Cardiometabolic Consortium on secondary prevention strategies in MI. Cardiac rehabilitation stated in the 11th statement, all patients should be offered a cardiac rehab program, particularly after STEMI, with strong evidence and high level of agreement. Cardiac rehab should be provided as a structured program, which includes exercise training, lifestyle advice, and psychological counseling. At the end of cardiac rehabilitation program, the patient must resume working, sports, recreation, and sexual activity. The question is, what is the magnitude of cardiac rehab? So the systematic review of 63 studies randomized to exercise-based cardiac rehab to conventional care, cardiovascular mortality is reduced 26%, and hospital readmission is reduced 16%. It consistent across patients type, high or low risk, intervention type, comprehensive or exercise-based, and setting of rehabilitative care, center, home-based, or combination. Okay. In guideline, European Preventive Cardiology, exercise-based cardiac rehabilitation is class 1 recommendation with level A. For ASCVD even, for patients with heart failure, and also there is a home-based cardiac rehabilitations in guideline class 2B. How about in PAD, peripheral arterial disease? So in peripheral arterial disease, also the guidelines state that cardiac rehabilitation is in class 1 with level A. Is it cost effective or not? Baseline on coherent library review. It is cost effective, yeah, in terms of gain in quality adjusted life years. So that's why in our center, we try to know what is the predictors of functional capacity improvement after cardiac rehab, because we know the increasing of one METs, metabolic equivalence, is related with decreasing of 12% of mortality in the future. Yeah, so we perform in small studies with our rehabilitation programs, 4 to 8 weeks, twice weekly, 6 to 12 sessions, moderate intensity aerobic exercise. And the result, yeah, we can see the mean improvement is 0.87 METs before and after only 6 weeks program. There is also some predictors. Okay, now we back to the theory. What is the exercise prescription actually? Yeah, we can see here basically FITT, yeah. So we can't just see people, some patients doing exercise, but we should know the exercise prescription should be stated about frequency, at least 5 times a week. Intensity, moderate intensity, time is 20 to 60 minutes. And for this aerobic exercise, such as jogging, biking, swimming, and walking. Yeah, moderate intensity definition is to have reserve heart rate 40 to 60%, and about ball scale 11 to 15, about something hard. Yeah, you can still smile, it's still low. Yeah, or if you still can singing, it means low intensity. But if you're already flying, so it means you have a high intensity level. Resistant exercise is also very important for exercise perception. The frequency is 2 to 3 times a week. Low for moderate level resistance for cardiovascular patients, 10 to 15 repetitions, 8 to 10 tools. Okay, now we have an intermezzo here. Questions. 58 years old patients had elective valvular surgery 6 days ago. She is a retired lawyer and lives at home with her husband in two-story house. She usually does most of the cooking, and her main physical activity is light gardening. During the early rehabilitation period in the hospital, you and your team focus on improving her physical function in preparation for his return at home. So which of the following exercise options would you least advise in this early phase? Walking 60 meters in flat corridor, walking up a flight of stairs, upper limb flexibility exercises, lower limb strength training exercises, of walking 30 meters on the flat outside. What do you think? Okay, to answer these questions, we should know in the early phase, we should form aerobic exercise. Yeah, we should usually put the strength training on the list one. Yeah, so the right answer is D. The least advised is the one which is strength training exercise. Okay, there is a wide range of difference between every patient, but usually they still should ongoing, not lying in the bed, and see what is the best. Yeah, and then we can adding for the next exercise for the progression. Okay, we should know the highest the functional capacity, even in normal subjects or in subjects with cardiovascular disease, will improve the outcome. So that is a principle for us who practicing in cardiac rehabilitations. And what is the mechanism? So exercise training, not just only work in cardiac, but also in vascular, neurohumeral, and also in non-cardiovascular effects. It will act in skeletal muscle, ventilation, and hemorrhagic. Yeah, we can see here for every condition, normal FV function, systolic heart failure, diastolic heart failure, cardiac valves, and in every details of the vessels, yeah, it has some beneficial effects. This is also important for anti-arrhythmia effects. So maybe it can explain why cardiac rehabilitation can reduce hospitalization, in some studies can reduce mortality, and the must be one is improving quality of life. Okay, and we can see here also from the Journal of Hypertension, exercise training regularly can enhance VEGF and angiopoietin, that disease can promote pro-angiogenic pathways, so it can have beneficial effects in ischemic heart disease. Besides that, it also can improve metabolization, increase insulin sensitivity, and also has a vasodilator effect with nitrate oxide effect. Okay, in heart failure, don't forget, cardiac rehabilitation is the fifth pillar in heart failure management alongside the drugs. Yeah, What is the mechanism? Actually, in heart failure actions study, in heart failure, exercise training can also reduce hospitalization, and adjustment also can reduce mortality. It has so many effects from the cardiac itself, reduce of filling pressures, improving cardiac output, improving the sympathetic and vagal tone, reduce RAS system, reduce inflammation, improving in fiber compositions, the musculoskeletal type 2B can improving to type 1, and also improvement in endothelial function in every cell. And don't forget, it also will increase your lung capacity and can reduce the shortness of breath. Okay, class 1A for heart failure, reduced heart failure hospitalization. And this is from sports cardiology guidelines. Yeah, we can see here, we act from promotion, firstly, diagnostic, risk stratification, shared decision-making, and also treatment for all of cardiovascular condition until reach its goal. Yeah, okay. Let me trigger you also with the second questions. You are asked to refer 63-year-old man who has recently survived a cardiac arrest to an appropriate cardiac rehabilitation program. He has an ICD inserted and has now returned to work as a checkout staff in her local supermarket. She lives with her husband and her hobbies including knitting and cooking. So what is the most appropriate management and rationale at this stage? Yeah, so she's in after ICD. Yeah, so we think she had experience of lethal arrhythmia, and also might be reduced ejection fraction heart failure. So we revert to an exercise-based cardiac rehabilitation, as it will significantly reduce her sedentary time at home. So just as simple as that. Or B, revert to an exercise-based cardiac rehabilitation program, as it will significantly reduce cardiac-related hospital readmissions. C, revert to an educational-only cardiac rehabilitation program, that it could reduce cardiovascular mortality. Or D, yeah, we haven't discussed it yet, do not revert to cardiac rehab because is it contraindicated. Or E, defer cardiac rehab for 6 months. Okay. For these questions, the answer is B. Yeah. So because the number A, it's not right. Cardiac rehab is to reduce cardiac-related hospital readmissions. If number C, only education, it won't lead significant improvement in mortality. For D and E, yes, ICD is not contraindicated for cardiac rehabilitation and can be started as soon as after the operation or in average 1 month, yeah, after the procedure. Yeah, so the sports cardiology guidelines stated exercise in patients with cardiovascular disease can be obtained in many conditions. Yeah, preventive, aging, myocardial bridging, heart failure with reduced or preserved ejection fraction, valvular heart disease, hypertrophic cardiomyopathy. Yeah, there is a new guideline or a new review about this. Myocarditis, pacemaker. Yeah, that's what we have the case before. And congenital heart disease. I have an example, a case. It's very interesting. I want to show to all of you. 25 years old guy with hypertensive cardiomyopathy, still differential diagnosed with obesity-related cardiomyopathy. It comes from heart failure clinics from my colleague. and the ECG is sinus tachycardia, and the ejection fraction at first 18%, and cardiac MRI showed mid-wall enhancement at basal anteroseptal and infralateral, and also there is an edema. Yeah, so the findings can still be an inflammatory cardiomyopathy or hypertensive cardiomyopathy as differential diagnosis. But from the clinician from heart failure clinic stated this is obesity cardiomyopathy because there is no signs of inflammatory cardiomyopathy. Yeah, what we've done, we started 6-minute walk test first. Yeah, the distance is only 324 meters. The max is only 2.60, and then we started continuous exercise training with only 1.7 kilometer per hour, and the inclinations 2%. Yeah, why? Because this patient is obese, 160 kilograms. Yeah, before we can see here 160 kilogram. Yeah, yeah. So we should be careful with his knee. This is his patient's. Yeah, this is in the third phase. Yeah. Okay, we firstly started with the bicycle, and then we can go to at last on the more speeder, yeah, with 4.4 kilometer per hour and 60% inclination, yeah. Okay, we also manage his dietary. Okay, we can see here the time to eat is only 3 times with strict grams, yeah, rice and also proteins and vegetables. This is medications. Yeah, we can see here only in 1.5 months the weight is reduced 9 kilograms, and right now already reached 135 kilograms. Functional capacity, we can see here, improved to 8 METs, and also the echocardiography also improved with the medication also becoming 49%, yeah. So that's interesting case. Now we go to another questions, yeah. 50 years old, heart failure and diabetic. To start outpatient cardiac rehabilitation program 2 weeks after elective PCR. What is the most appropriate precautions and further response? What you check before starting the exercise program? Check blood glucose, hemoglobin, increasing in weight, check the limb, and also check echocardiography for a thrombus. Yeah, actually, most of the answer quite good, but if I would choose the most appropriate, so yeah, E, yeah. If thrombus present, so should delay exercise. Hemoglobin is usually for post-surgery case. Yeah, and then increasing in weight, there is a number. If more than 2 kilograms, so delay the exercise. We should mention about heart failure. Bilateral leg edema, it could be comes from CVI. You should check it first. And blood glucose, you should check it in every patient with diabetes in the first time of exercise, yeah, pre and post exercise. Okay, next, the challenges, yeah, my second topics, challenges in CR implementation, what the ideal and what is the reality. Yeah, so I will bring my colleague study in Makassar. He said that the risk of recurrent cardiovascular events in Indonesia is still high. Yeah, more than 65% after cardiac events still in risk to have another or recurrent cardiovascular disease. How about from Inter-Aspire study? Inter-Aspire study is very good. It's a collaboration partnership between Asia Pacific Society of Cardiology with another heart federation in the world, the National Survey of Secondary Prevention of Cardiovascular Disease. Yeah, Indonesia, Malaysia, Singapore, yeah, all of practicing here. is a member, yeah, and cardiac rehabilitations actually not high, yeah. Maybe there is also still a bias here in Indonesia because the center that is included is from Preventive Cardiology Center. So maybe it will higher than its reality. Yeah, but we can see here another part of the world, usually not high. Yeah, also the 10-point score of core component of secondary prevention. We can see here all of the world not so high, yeah, to reach more than 8. Yeah, in average, around, yeah, maybe the most frequent is on the average of them. Yeah, Malaysia, I'm sorry for the speaker of Malaysia, from the sample, yeah, very high, yeah, on the low achievement of the target. Okay, in Southeast Asia, so I will mention, yeah, there's a lack of funding, yeah, and also there is only 54% in Southeast Asia region that have cardiac rehabilitation. So above the barrier, we can separate to 5 categories: individual, health history, environmental, logistical, and health system. Yeah, and the most reported barrier related with age, comorbidities, lack of support from friends, family, distance, and cost. Okay, another slide is from India, yeah, in middle income country. And also, this is very interesting and I think related with our daily activities. So in Thailand, they explore even 62% of respondents didn't know about phase 2 cardiac rehabilitation. The another reason is transportation and also unable to take leave due to work schedule. Yeah, okay. Now, what is the strategies to translate? Okay, from the reference, we shouldn't be based on just hospital-based, but we can try home-based and community-based. Yeah, also for referral system. So we can make automatic referral. So it will increase cardiac rehab participations and it will improve patient outcomes and enhance cardiac health. Yeah, this is a sample of in our hospital while patients performing 6-minute walk test in first stage of cardiac rehabilitation, we already give this this paper. They will bring it to the doctors while they control in the next week. So the doctor in the outpatient clinics will be easy. Yeah, just sign and then the patient will be sent to cardiac rehabilitation. Home-based cardiac rehabilitations from choice trial and systematic review. Yeah, it have beneficial effects and safe and low, just low incidence of adverse effects. Yeah, home-based cardiac rehab is class 2B. This is also another sample that what we have performed in our center. We started phase 3 cardiac rehabilitations 4 months ago to make patients that have just finished their second phase of cardiac rehabilitations to still have meet and exercise once a week. It needs a lot of collaborations, a lot of funds, not easy, yeah, but after some collaborations, yeah, we can manage it. And until now, it still persists with higher rate of attendee. Yeah, this is a sample also. We usually give education program. So, okay, there's also another reference to manage the cardiac program. We should flexible. So in the guidelines of Australia and New Zealand, cardiac rehabilitation programs should be flexible with a wide range of options and structures. One example is with aqua, yeah, aqua-based cardiac rehab. So I also have tried it in my private hospital. octogenarian patients, yeah, very happy while he's having a swimming or aqua-based cardiac rehabilitations. Yes, so he for a while he doesn't look like have high motivation, but after this session, he looks like a child again, smiling always, yeah, in front of his family, yeah, and then he can finish his cardiac rehabilitation program 2 times a week, 1 times in swimming pool and 1 times in treadmill. Yeah, swimming also have another advantage for obesity person, osteoarthritis person, patients, and if we can manage him to have flexibility training and resistance training. Okay, the last digital healthcare. One of my colleagues, Dr. Bambang Dwi Putra, has also made it. Yeah, he with the team make like applications. So I'm sure the process of rehabilitation program can be managed with this kind of applications. Yeah, from the theory, don't forget we should adopt with cultural perspective. Don't forget about the legal aspects. We should regularly manage the health information, so it needs a cost, health economic evaluations, and also humanistic care. Okay, the last questions. This is also interesting for managing the cardiac rehabilitation program. After 1 year, a team evaluate new cardiac rehabilitation program. Only 22% of patients that are referred to hospital's cardiac rehabilitation program that actually attend the classes. Which of the following strategies is least likely to improve uptake? A, ensure that the acute cardiology teams initiate referral to cardiac rehabilitation. B, offer more follow-up medical appointments post-discharge to all patients. C, create additional women-only cardiac rehabilitation classes. D, offer additional choice for a home-based program. And E, improve access to outpatient programs at various times. Okay, the least likely is B. Yeah, I think the C, make women only, is very important, especially in my country. And also A, D, and E is an innovative way. Yeah, for B, it's just for administration, but it doesn't improve actually the cardiac rehabilitation attendee. Okay, as conclusions, cardiac rehabilitation is class 1 recommendation in most of cardiovascular diseases. Secondly, there are indeed many obstacles, but they are not without solution. 3, awareness of the direct benefits of rehabilitation and the addition of subspecialists or fellows who focus on rehabilitation are a main key. Okay, thank you so much. I hope you also know the man in the center, yeah? Okay, thank you so much.
Thank you, Dr. Badai, for a wonderful presentation. I learned so much. You covered everything from the basic principles to more advanced principles and an up-to-date information guideline based on the role for CR in our clinical practice. And importantly, I think you shared, very pertinent real-world examples of how we can all implement it better in our current practice, especially for more difficult to access cohorts like women, the elderly, and even cardiometabolic patients like the obese patients. This is a wonderful session. I don't see any questions in Q&A. I advise our participants to use this time to ask our expert questions. So while waiting for that to flow in, Dr. Badai, I have some questions of my own with regard, I think, to the digital element, because we know that all across the region, telehealth and digital solutions are generally quite well adopted. Yeah, since the pandemic era. What are your thoughts on hybrid cardiac rehab programs that combine in-person and virtual elements? Are they, in your experience, or are there any studies that show their efficacy compared to traditional models?
Okay, thank you for the questions, Natalie. There is already on the guideline, on the preventive urology guideline. It is class 2B, and they stated about the reference, about the study. So I believe there's already a study about that, and looks like the result is in the, this is good to hybrid. It makes sense, reliable, and from our perspective, we believe, we can do it. It's accessible and flexible, and and about the result, exactly the result, even though there is still some limitations, but the result is good. Maybe why it doesn't state it on the class 1 recommendation, maybe due to the limited of sample size, not multi-center, and also maybe due to not really reliable on the clinical practice. So even in my experience, it's very hard to do that because it needs so many human resource, and it also need the cost. Yeah, so I also want to hear from all of you here in our country, middle country like us, while even the insurance only cover the official supervised rehabilitation program in the hospital, how can we manage something like this that can be officially here? Okay.
Yeah.
But I believe in the future it will expand, and if we already patient on that, we will find a way. Yeah.
Yep. Yep, and I think also the very important point you make about being culturally sensitive does inform practitioners, and also sometimes the guidelines may not always apply depending where they are written. And I think it's up to the Asia Pacific segment to try and create programs that are best suited for our cohorts, our Asian cohorts. Okay, I think we are at 6:40. And this is when our next lecture must start. Dr. Badai, thank you so much for sharing your up-to-date insights. I will hand over to Dr. Wishnu and Dr. Teo.
Thank you.
Yeah, I think we still have lots of questions actually to discuss regarding this topic. Probably we can discuss it later after the second presentation. So I would love to ask Dr. Tee Joo to invite the next speaker.
Yes, so thank you. We'll save the rest of the questions for later. So it gives me great pleasure to introduce our second speaker, Dr. Mugilan Sundarajoo. He's a cardiologist from Institut Jantung Negara, Malaysia, and he will be speaking on preventive cardiology. Dr. Mugilan, please.
Thank you very much, Dr. Tee Joo. So good evening to everyone. I'm Dr. Mugilan Sundarajoo. I'm an interventional cardiologist in Institut Jantung Negara, National Heart Institute in Malaysia, and it's a pleasure to be here with you this evening in sharing about preventive cardiology. Thank you very much to the APSC committee, the co-chairs, and also the esteemed panelists today. I hope everybody will bring back a point or two at the end of my presentation. So I'll start off. All right, so preventive cardiology. Now, this is the outline of my talk for today. I'll be speaking about the stepwise approach to individualized cardiovascular disease prevention. What are the age-specific risk thresholds in apparently healthy people? This is a new concept. I will explain this further later on. What is the estimation of lifetime CVD risk, interventions at individual levels, and also the targets and also evidence. Now, we are moving towards stepwise approach in many things, including hypertension, diabetes management, and of course, CVD prevention also is the same concept, a stepwise approach. So we have a look at a group of patients, different categories of patients, and go ahead with prevention goals for all. Step 1, the initial prevention, and step 2, the intensified prevention. So what are the categories of prevention that we are looking at? Which group of patients? First will be the apparently healthy persons, which I'll explain in a while. Those with established ASCVD, those patients with type 2 diabetes mellitus, and those with specific risk factors which increases your cardiovascular risk, such as chronic kidney disease and also familial hypercholesterolemia. Now, when you speak about the categories of patient, when you have a look at patients without established atherosclerotic cardiovascular disease, those with no other risk factors like DM, CKD, or familial hypercholesterolemia, how do you move forward? How do you see what exactly is the risk and also the therapy benefit estimation? This is through your 10-year CVD risk estimation. So those below the age of 70 years old, you use score 2, and those above 70 and above is score 2 OP scoring system. And those with chronic kidney disease, you must always take into account not all CKDs is considered high risk. Moderate CKD is considered high risk. So EGFR of 30 to 44. And severe CKD, where the EGFR is less than 30, is considered very high risk in comparison to moderate CKD, which is only high risk. And the moment someone actually has familial hypercholesterolemia, you're already considered as high risk. But what about those with type 2 diabetes mellitus? So the moment you have diabetes mellitus, you're already considered moderate risk. If you have, established atherosclerotic cardiovascular disease, then that's considered very high risk. But if you do not have established ASCVD, but you have target organ damage, that's considered as high risk. And I think everybody knows this. The moment you have established atherosclerotic cardiovascular disease, you're considered very high risk already. And what is the importance of you having these different categories? Because your treatment goals is not the same for all categories. It's very much individualized. Now, what are apparently healthy persons? So this, in a nutshell, is people without established atherosclerotic cardiovascular disease. So what I wrote here is event or plaque. So that means patients never came in with, say, unstable angina, non-ST elevation MI or an MI, or even, risk modifiers like when you use a multi-slice CT scan, there's no evidence of atherosclerosis per se. And there's no, patient does not have any CKD, any diabetes, or any evidence of familial hypercholesterolemia. So you can see here, for apparently healthy persons, the step 1 is still for you to stop smoking, lifestyle recommendation, and maintain a systolic blood pressure of less than 160 millimeter mercury. And based on the age, you go ahead and do your risk scoring using a risk calculator, either a score 2 or a score 2 OP. And then you consider your risk modifier. For those below 70, you consider what is their lifetime CVD risk and what is whether they have more benefit from the treatment per se. If they are above the age of 70, then you have to take into account few other things such as frailty, polypharmacy, and also patient preferences also. Then lastly, you target your blood pressure, your systolic blood pressure for around 130 to 140, that's class 1, and targeting your LDL-C less than 2.6 millimole per liter, and that's class 2A, whereas targeting a LDL-C of less than 2.6, the class 2B for those above the age of 70 years old. Now, why we have to be very aggressive in treating a apparently healthy person is that if you start the treatment much earlier, your lifetime benefit of lowering your systolic blood pressure by 10 millimeter mercury is actually very, very profound. You can see if you start much earlier, below the age of 60 years old, you can see more benefits in comparison when you start the patient later on in their life. And you also get a lifetime benefit if you go a bit more aggressive in treating the patients with statins. You get a certain number of extra years free of cardiovascular disease when you reduce your LDL-C by 1 millimole per liter. Now, looking at this, okay, this is a great slide. When you see patients, when you calculate their risk, have a look at this. So in those above the age of 70 years old, when the risk is less than 7.5%, I give you an example. So let's say someone is above the age of 70 years old and the risk is around 8%, then the patient falls under high CVD risk. So treatment should be considered. But let's say the same risk, around 8%, is in someone at the age of around 40 plus. Yeah. So patient automatically becomes very high risk because you have to look at the whole spectrum of when the patient can actually develop progression of ASCVD per se. So when the patient actually drops around this category, then the treatment is considered recommended. And if patient is more than the age of 70 years old and is very high CVD risk, statins, class 2B for this particular cohort of patients. So we are still waiting for STARI trial data, which should be available sometime soon. This is on primary prevention usage of statin for those above the age of 70 years old. So that'll be quite interesting that we can discuss maybe in the next webinar. We have to look at other risk modifiers. I think it's worthy for us to mention here things like, your stress symptoms, the psychosocial stresses. There's a class 2A, and also calcium artery scoring, CAC scoring, and also your multi-slice CT scan to look for any evidence of atherosclerosis. That's class 2B. And let's say your center does not have this particular modality, then you can ask the patient to do even a carotid ultrasound, which is widely available in a majority of cardiac centers. And we have to also take into account the ethnic subgroups, which can vary the atherosclerotic cardiovascular risk. So I'll go straight to our question. So this is a 55 years old gentleman, smoker, came into us with a blood pressure of 150/90. The SCORE2 risk estimation system, according to that, which of the following factors is not considered in calculating his 10-year risk of cardiovascular death? A, age, smoking status, total cholesterol.
Mugilan, I think you got muted.
Can you hear me now?
Yes, yes, now good.
Okay, great. So back to the question.
Sorry, your voice is lost again, Mugilan.
I suspect it's his internet connection.
Yeah, likely.
Mugilan, if you can hear us, maybe you can try turning off your video so that it reduces the bandwidth on your side. Okay, we have you back now. Mugilan, can you hear us?
Yeah. Yes.
Yeah,
Can you all
maybe
see my
can
slides?
turn off your video so that you can reduce the bandwidth. I can hear you and we
Okay.
can see your slides.
Okay. All right. So back to the question just now. So basically what we come to see here is that, can you hear me now?
Yes, yes, can.
Oh, okay, great. So the answer is D, family history of premature cardiovascular disease. So a strong family history of premature CAD is a major independent risk, but the problem is this is not captured by your SCORE2 calculation. Yeah. So sometimes you get a low SCORE2 score, and this will eventually give a false sense of security. Then comes the question of other things. Even if this patient's cholesterol is normal, what will be the specific values that is not taken into account? And is the patient actually having pre-diabetes, or if the patient is having any sedentary lifestyle? And if there's any availability of advanced testing, tests such as lipoprotein little a, whether that will be helpful in testing his likelihood of developing cardiovascular disease. So which scoring system do we use? Now, SCORE2 system is specifically created for European population. Framingham Heart Score is basically for US population. So this shows that SCORE2 may be a bit more accurate for Europeans, but Framingham may actually overestimate the risk in some European patients. Yeah. So the similarities is that both Framingham and SCORE2 systems it estimates a 10-year cardiovascular risk. SCORE2 focuses on cardiovascular death, whereas Framingham actually focuses on fatal and non-fatal cardiovascular events. So you want to compare both is going to be a little difficult here. So this is a paper published by our colleagues from Asia Pacific. So this is in Journal of APSC. So this is a risk prediction of cardiovascular disease in our region. Yeah, the SCORE2 Asia Pacific model. So they went ahead to look at all the cohort of patients. Then eventually group them up according to our population and our risk factors. So everybody can use this online calculator, and subsequently they grouped it up to low, moderate, high, and very high risk patients so that we can re-stratify even further and then give them a bit more, a better guided preventive strategy. So question 2, this is a 62 years old man being evaluated for primary prevention of cardiovascular disease. He has no family history of premature coronary artery disease, but he does have diabetes. So his calculated 10-year ASCVD score is actually high. So according to current guidelines, which of the following represents the most appropriate LDL-C target and therapeutic strategy for this patient? So LDL-C of less than 1.8 and a 50% reduction, less than 2.6 millimole per liter and 40% reduction, 3.4, 30%, 4, 20%, or there is no specific target for the LDL-C. So in the interest of time, I'll give you the answer. So LDL-C of less than 1.8 with 50% reduction, from baseline levels of LDL-C with statin therapy. So have a look at this. So this is patients with type 2 diabetes mellitus. This is from the 2021 ASC guidelines on cardiovascular disease prevention. So step one is always like what I mentioned just now, stop smoking. And then another thing is that you want to maintain an A1C of less than 7%. Then you have a look if the patient has established ASCVD or not. So without, then if the risk is high, you want to aim a systolic BP of 130 to 140 and an LDLC of less than 2.6, which is a class 1. Then you look further, look at what exactly is the 10-year CVD risk and the lifetime risk and whether they have benefit from you treating the patient. Then you come to realize that, your targets should be much lesser, your LDLC of less than 1.8 millimole per liter. Then subsequently, in case of those with high risk, with no established ASCVD, the usage of SGLT2 inhibitor and GLP-1 receptor agonist is considered a class 2B. Whereas if you see on the other side, those with established ASCVD or target organ damage, you realize that the usage of both these drugs is actually a class 1. So among the lipid recommendations, what I think this is something that most of us already know. If let's say someone is not achieving their LDLC target, then you want to add on an ezetimibe, and let's say you're still not achieving target and you do not have familial hypercholesterolemia, you want to step up the therapy even further by adding a PCSK9 inhibitor, and that's a class 2B indication. And in terms of screening, nowadays we can actually do a HbA1c screen. There's a class 2A. And for those who are actually motivated to try, you can also use a low-calorie diet, and subsequently maintaining the weight and have a look. And because some of them can actually have DM remission if it started at an early phase of diagnosis per se. And when you see this, metformin is considered first-line therapy, but, you have to keep in mind if they do not have previous ASCVD, CKD, or heart failure, then that's considered first-line. But for those who have ASCVD and also CKD with type 2 diabetes mellitus, the use of GLP-1 receptor agonist, SGLT2, is considered class 1A indication. Now, for those with established ASC, I'll skip that, established ASCVD, our target of LDLC should be less than 1.4. And together with your reduction of LDLC at least more than 50% from baseline. And also, let's say if the goals are not actually achieved with statin, you must consider the addition of ezetimibe. And subsequently, if that's still not achieved, then you consider the addition of PCSK9 inhibitor, which is also a class 1 indication. Something interesting here is the recommendation of anti-inflammatory therapy. So a low-dose colchicine may be considered as a part of secondary prevention. So this around 0.5 milligram once a day. If let's say patients who actually comes in recurrent events, you can consider this. So looking at the guidelines for hypertension, the 2018 ESC/ESH guidelines, so it was broadly classified as 7 groups here: optimal, grade 1 to grade 3, or even isolated systolic hypertension. So this was in the past. So what has changed in the recent guidelines is that now we're taking into account patients who are called as non-elevated. Now, when you look at major trials such as SPRING trial, you come to realize that patients who actually have hypertension at the age of 70 or 80, they tend to be normotensive when they're at the age of 40 or even 50. So we must respect hypertension as a progressive disease, and we must be able to catch them much earlier. So hence why they actually came up with this word non-elevated and elevated blood pressure. So that's 120 to 139 systolic and a diastolic of 70 to 80, and hypertension is considered 140 over 90. So from this slide, you can see that not only taking into account office BP, but they also had a look at home blood pressure monitoring and also ambulatory BP monitoring. So looking at the major trials, your SPRING trial, ASPID trial, and also the Chinese research paper, most of the patients actually had increased cardiovascular risk. And when you come to look at this cohort patient of elevated BP category, when you go ahead for treatment, which is a bit more intensive, you come to realize that not only major cardiovascular events, but also the death is much, much lesser in these patients. So what are the protocols for confirming hypertension diagnosis? First and foremost, office screening. Next, you want to confirm it with the ambulatory blood pressure monitoring or home blood pressure monitoring. And once you get your diagnosis, you want to incorporate the SCORE2 calculator to see what exactly is their risk. And of course, if somebody actually, most of the time you tend to use an out-of-office measurement, but if someone comes in with hypertensive emergency, you want to take into that into account and treat them accordingly. And what is prudent for me to mention here is that you have to look really hard for hypertension-mediated organ damage. So you do your screening, things like urine ACR to look for albuminuria, and then go ahead and do an ECG to look for LVH, echocardiography to look for diastolic dysfunction, and even assessing other arteries like a carotid and femoral ultrasound to look for plaques, and also cardiac CT. So treatment by guidelines, well, most of the guidelines actually states that you want to start the patient on a single pill combination. Yeah, so you want to start off initially with low dose double combination therapy, and subsequently you can go ahead with low dose triple combination, and then maximally tolerated combination of a higher dose triple combination therapy. And this is also backed up by the International Society of Hypertension guidelines published in 2020. It also states the same thing. But I would like to just highlight this. So in what patients do we start initial monotherapy? So this is in those who actually have this elevated BP category. So you can consider initial monotherapy. And in those patients with moderate to severe frailty, and those who have symptoms, side effects such as orthostatic hypertension, and those elderly patients above the age of 85 years old. This is another paper by our colleagues in the region. This is an overview of burden and challenges for hypertension in Asia Pacific. So the main challenges that they come to see here is, at multiple levels, at national level, healthcare level, and so individual level, which we need to focus on improving even further, because secondary prevention seems to be something that's very good, but primary prevention per se, and also especially hypertension in our region, the treatment in both primary and secondary prevention is considered still very poor, and is still work in progress. And patients with, this is a paper, actually, a local paper in Malaysia. So this is the Malaysian Working Group Consensus Statement on Renal Denervation. I read this paper, and they actually highlighted two things. So two of the biggest thing that we are not doing enough here is, number one, excluding secondary causes. And secondly, we are not, secondary causes, and the second one is actually non-adherence to therapy. So we're picking up the wrong patients. Yeah, so we are not advising the patients properly, not monitoring them. If we can do both of this and the patient is still having resistant hypertension, then with shared decision making, we can consider renal denervation. So question 3. Maria is a 45 years old woman who has recently become more concerned about her risk for type 2 diabetes mellitus. She has family history of diabetes. Both her aunt and also her father was diagnosed in their 50s. So she is very sedentary. She works a desk job, not much of physical activity, and her diet is also very poor. Her blood pressure is borderline, 132/80. Her cholesterol is 5.2 millimole per liter. HDL is good, 1.2. She's a little overweight. So based on this information, what is the diabetes risk score assessment? So either low risk, moderate risk, high risk, or very high risk. So in the interest of time, I'll just give you the answers. Moderate risk, so lifestyle changes is recommended. So where did I get this moderate risk from? So this is another risk calculator that you can actually use. This is a good prediction tool. This is the SCORE2 diabetes risk calculator. So you just key in data like your age, sex, smoking, diabetes, systolic blood pressure, total and HDL cholesterol, and subsequently we can group up the patients to what risk they are in. And if the patient is already having ASCVD, it's quite obvious the patient will eventually have very high risk. But if the patient doesn't have established ASCVD or target organ damage, then you can group up these patients to all this risk and treat them accordingly. So management of patients, I just wanted to highlight to you, in most patients actually who have diabetes mellitus, you want to reduce their severe risk. So your GLP-1 receptor agonist and SGLT2 is considered a class 1 indication, especially those with extra risk of CKD and also heart failure. And this is another thing. So I just wanted to highlight this particular point here. In patients with diabetes, it's prudent for you to routinely screen the patients for their eGFR and also the urine ACR and the class 1B indication. And this is a great slide to show that, patients with low to moderate risk, your first line will still be metformin. But the moment you're high risk, you can think of incorporating the patient. High risk, that means there's no established ASCVD. You can consider, adding on GLP-1 receptor agonist and SGLT2 inhibitor, and that is class 2B, whereas those patients with established ASCVD, GLP-1 receptor agonist and SGLT2 inhibitor is considered very high risk. Is considered class 1 indication. And this is just to show you the LDLC target. I think we know this. Very high risk is less than 1.4, whereas moderate risk is less than 2.6 millimole per liter, and high risk is 1.8. All of this is actually class 1 indication. So the reference for this talk is this, your 2021 ASC guidelines on prevention, the American Heart Association guidelines, and this, and some of the Journal of APSC review that I showed you all just now. Thank you very much.
Thanks a lot, Mugilan. It's a very nice session. So, Tee Joo, do you please lead us with a discussion for the session?
Yes, thanks, Vishnu, and thank you, Mugilan, for the very insightful and very detailed presentation. Let me take a look at the Q&A. So we are still waiting for the questions from the audience. So for those who are listening in, please feel free to type in the Q&A box. So let me just reinforce a few things, and before I ask some questions on my own, I think the part about the time cause effect that you mentioned is extremely crucial, because a lot of people don't realize that the earlier you start prevention, the larger the magnitude of prevention and risk reduction. A lot of people feel that, even if they start a bit later, they might still get the same effect, but that is not true. And of course, the tables that you've shown is clearly demonstrates the evidence. So I think it's an important concept that we can use. I have some questions. Perhaps you can enlighten the audience about some of the other non-pharmacological ways to deal with prevention. For instance, diet and exercise, because a lot of people talk about lifestyle modification. We just lump it together. But perhaps in a succinct way, what can all the healthcare providers listening in here, I know there are a variety of them, not just doctors, nurses, allied health, so many of them, so at all the various touch points, how can we, simplify some of these lifestyle modifications that will help our patients?
Yeah, that's a great practical question actually. So what I actually tell my patients is that I've given a talk on this also before, regarding exercise. I think I'll be invading into Dr. Badai's territory, but exercise per se, if someone actually has established atherosclerotic cardiovascular disease, be it the stroke or also a heart attack in the past. So I think cardiac rehab is very important, but everybody must be mindful of the prescription of exercise that we give patients. So what is important is that you need to have a graded exercise regime. So start off from slow, then subsequently you develop your stamina and also intensity of that particular exercise. And for those who are considered high risk with no established ASCVD, on statin therapy and also antiplatelets, what I usually advise them is that go for a moderate intensity exercise, at least for 150 minutes in about a week. So what is moderate intensity exercise? So a lot of patients actually ask us, they actually tell us that I'm actually very active. So things like, I do sweep the floor, climb the stairs at home and things like that. So I always tell them that is not moderate intensity exercise. Then they have a rebuttal. They say, doctor, but I sweat. Yeah, so you have to educate. I think it's our job to actually educate our patients. So I tell most of our patients to actually have a smartwatch. So you have a smartwatch and then you get your resting heart rate. So based on your resting heart rate, just add 50% to that. So let's say your resting heart rate is 70. So you want to aim about 105 to 110 heart rate, at least for about 30 minutes in a day for about 5 days in a week. So I think that's something that we need to reinforce to our patients. Yeah. That, and then regarding diet, I think there's a lot of fat diet recently, keto diet and intermittent fasting. Well, I'm not against any of that. There is some evidence that going with the Mediterranean diet is considered helpful also in both the progression of atherosclerotic cardiovascular disease and also the prevention ASCVD. So these are some of the takeaways.
Yeah, thank you very
Anything
much.
else? Yeah.
Yeah, so I think the lifestyle modifications wise, maybe the audience can also refer to the European Society of Cardiology prevention guidelines, preventive cardiology guidelines. There are a number of class 1 recommendation. So Dr. Mugilan mentioned, very, very aptly about the exercise bit. So just broadly speaking, it used to be a magic number of 150 as a target, but now it's actually 150 as a minimum. So you can actually go up much higher. And moderate intensity wise, I think also Dr. Badai did mention, if you can speak while doing the exercise, then that would be actually on the lower end of the spectrum. But or sorry, if you can sing while doing the exercise, then it will be considered low intensity. But if you can't sing, but you can still speak in maybe 1 or 2 sentences, then that should cover as a moderate intensity for those people who may not be able to have smart watches for that matter. And then maybe before I continue, any of the other chairs have anything to add?
So I would love to raise a little bit of issue about prevention. So before that, I would love to thank Mugilan for a very good presentation, and especially this is very important for us as cardiologists because we might not be doing specific things like intervention or rehab, but we all will do prevention. So this is a topic that we can all relate. And I want to ask a very specific topic like a CT calcium score, Mugilan. What do you think of CT calcium score? Do you think it can be used as a prevention or screening tool for the population? So, for example, do you probably have a low risk patient but has a strong family history, and after you're doing a CT scan, you can found that someone probably have a calcium score of about 200 or 150 or 300. And will it change your attitude in treating those kind of patients?
Okay, all right. That's once again another practical question. So as we know, sometimes calcium artery scoring using a calcium modality CT scan basically is quite a good marker. But when you look at the guidelines, your risk modifier usually for those who are low to intermediate risk, then you can use your risk modifier. And these are patients who are considered asymptomatic. So then I will go ahead with CAC per se. But having said that, if the patient actually has symptoms, even the patient is intermediate risk or high risk, I probably proceed for a full multi-slice CT scan. And even then, if the patient is symptomatic, not all the time you actually have a calcified plaque. It could be a mixed plaque, a fibrotic plaque. I think this last few days I've been having quite a number of patients who actually had a calcium score of 0, but were very symptomatic. Looking at their MSCT, eventually I realized that there's a non-calcified plaque. So went ahead for angioplasty for this cohort of patients. So to answer your question, if it's low or intermediate risk and the patient is asymptomatic, then probably I will incorporate calcium scoring. But if they are symptomatic, notwithstanding whatever the risk they have, then probably I'll go ahead for the full MSCT.
Thank you.
Thank you.
Yeah, so maybe just to add, even going back one step further, perhaps, if given this scenario in terms of all the different healthcare providers listening in, perhaps we can also encourage our patients to go for screening regularly. Because when we talk about prevention, ultimately the patients that end up seeing a healthcare provider are but a fraction of the entire population. So, from where I'm from, Singapore, we have a nationwide screening process where we encourage patients to get screened for the major cardiovascular risk factors, including hypertension, lipids, and this diabetes as well. And it is also relatively low cost. And things like blood pressure, body mass index can also be done very simply at the primary care level. So I think that is a very important first step before we even get to calculating the individual's risk, 10-year risk, and then deciding what test to order. So along those lines, there's a question in the Q&A box that I put a link. So basically the score to Asia Pacific that you've mentioned, which is the newest updated risk score specifically calibrated to the Asia Pacific countries. Personally, I've tried the calculator, I've put the link there so that everyone can click on it and try it out. I encourage everyone to go and try it out because firstly, it tells you what are the different risk levels. It's calibrated to Asia Pacific countries. And secondly, it tells you the effect of certain treatment targets. For example, if you have a smoker and then you want to basically encourage the person to stop smoking, you can actually see what is the percentage risk reduction. Of course, because of it's not being validated yet, so it's still considered a research tool, and they advise not for clinical use, but we can use that as a reference point.
Ask to Tee Joo.
Sorry, come again?
May I ask? Yeah, may I ask you? Yes. Before in Indonesia, we have a consensus that we use WHO with certifications. So what do you think after the SCORV2 established and it is said validated, well validated? What should we choose? Because WHO's certification has a patient from Indonesia, yeah, including a patient from Indonesia. So how do you think?
Well, without going into specifics, I think whatever risk calculators depends on the population that has been studied. So if you want to look at what calculator to use, you need to look at the population that was evaluated in order to get that risk score. So if the population studied in the SCORV2 Asia Pacific from Indonesia is more representative of the patients you are seeing than the WHO risk calculator, then by all means use the SCORV2. But if let's say the WHO used a large population of Indonesian patients that is more representative of your population, then you can use the WHO. Yeah, so I think that can be applied to any country.
And the most important, maybe the implementation, right? The reaction, yeah.
And how easy it is to use, because a lot of scores without any calculator it's difficult to calculate manually. So if there is a calculator online, you can just key in a few data points and then click calculate, and it's automatic. Yeah. So there are a few more minutes. Maybe either Vishnu or Natalie, would you want to have any questions?
There are some interesting questions in Q&A, and probably Nat, you want to read some of them that has not been answered?
Okay. I actually do have a question with regards to high intensity interval training, especially because when it comes to CT coronary angiogram, increasingly we're picking up, potentially left main disease, and the plaques are usually partially calcified, sometimes even non-calcified. So is there data for the safety of HIIT in such specific cohorts, and how do you guys manage this in your clinical practice?
Okay. It's very interesting. Maybe Tee Joo,
Yeah.
do you know the answer?
I will defer it to Mugilan first.
Okay. Okay, we do see this quite often, sometimes when you see patients for screening and all that, and subsequently we pass them off stating that, your stress test is negative. Even your stress echo is considered negative, but eventually, few months later, they come in with a full-blown MI and it's a calcified plaque, So cases like this, I don't think we have a consensus. What do you guys think? Is there anything? But what I usually do is, even if stress test is actually considered negative, stress echo is considered negative, if the patient is highly symptomatic, I'll still go ahead and, do a MSCT, and if that's positive, and bring the patient to the cath lab based on the risk, actually. But I don't think we have data for this cohort of patients. Have you all come across the rest of panelists?
Yeah, there's I don't think there's data in this specific scenario where athletic individual has left main disease on a CT scan. But the problem with stress test is that the actual period of time that the patient is under stress can be anywhere from 10 to 15 minutes. Very fit ones, maybe 20 minutes. It is not representative of whatever exercise or sport they do. For example, running a marathon or triathlon, it can be like 3 to 4 hours or more. So you cannot replicate that, and you cannot sort of clear a patient just because the stress test is negative. But of course, if there is left main disease, I would strongly recommend the patient to initiate like preventive therapy, such as high intensity statins, maybe even aspirin, and then counsel the patient. So nowadays, there's a lot of this shared decision making that they have to look out for symptoms, they have to look after themselves when they exercise. If there's any symptom, please slow down or stop, and potentially they may have to get the left main fixed before they want to carry on exercise. That's my take.
So how about we read one of the questions from Q&A columns. So in cardiac rehab, how are we differentiate disease-related symptoms and simply unfit patients? Do you want to address that, Dr. Badai?
Symptoms and unfit patients.
Yeah.
Unfit, yeah. Okay. We can make sure about the functional capacity of the patients, right? So if the patient complaining, but objectively the patient has achieved normal functional capacity based on his or her age, so it might be symptoms come from the disease. Yeah. Okay, that's what I think. In another case, yeah, this is sometimes an art. Yeah, medical doctor is an art, right? So we should see the characteristics of the patients, the psychological of the patients, and we should always evaluate.
Yeah, so you will look at the symptoms and also the data subjectively, right?
Yeah, that's why actually in my early detection strategies for CAD, sometimes I really love and enjoy to practicing treadmill test compared with CT. Yeah, because in treadmill test we can see a patient in a whole human. Yeah, we can see the psychological. We can see whether the symptoms is occurred during the treadmill test. We can see his personality, and then yeah, it can add many data for us to manage the patient better.
That's great. Do you have probably another answer or another suggestion, Tee Joo, regarding the question? Differentiating really symptomatic patient or probably patient is just unfit, quote unquote.
Yeah, so in cardiac rehab, most patients would have undergone some sort of therapy, for instance, revascularization. So by right, they should not have any of their presenting complaint symptoms, for example, angina. So if that recurs, then the index of suspicion is higher. For some patients who need some objective sort of assessment, then we could put them on telemetry. We can or put them on a treadmill test and look for ST segment depression that for coronary artery disease patients that correspond to their symptoms. This is their angina or ischemic threshold. So if there are abnormal changes, then we can use that as a reference point, and then we can differentiate the unfit patients from these.
That's great. Totally agree. So I think we're running out of time, and I think we have to close this session. And I believe Natalie have some words and last stage for us.
Thank you all for making the time on the last day of Lunar New Year to log in for our 6th episode on cardiac rehab as well as prevention for the APSC-EECC Core Cardiology Review Series. We look forward to having you next month at episode 7. And importantly, shout out for the APSC in Busan, where you'll get to meet this wonderful team of experts in person and continue the conversations and make many new friends. Thank you all for your time tonight.
Bye-bye.
Sorry, can we do a group photo? Just a quick smile for me, please. Thank you.
Sure.
Okay, thank you.
Thanks a lot.
Thanks a lot.
Okay.
Thank you.
Thank you, guys. See you all.
Guys,
Good night.
thanks for
See you all.
inviting me.
Bye. Nice to meet you.
Bye.